Okay, hello. Welcome to part 2 of the digestive system. We had just finished talking about dysphagia, which is difficulty swallowing. If a person is unable to swallow enough nutrients in order to be healthy, and that's because they have fairly severe dysphagia, then they may have an enteric tube surgically placed in either the stomach, in which case we call it a gastric tube or a G tube, or in the jejunum, which is the middle part of the small intestine, and in which case it's called a J tube. So this tube, an enteric tube, can act as a supplement. So for example, if a person can swallow some food, then they take as much food as they can in through their oral cavity and swallowing, and then extra nutrients are given then directly into the stomach or into the jejunum through this enteric food, enough for them to be healthy. In some cases, if somebody has very severe dysphagia and they can't swallow at all, then they may in fact take all of their nutrients and medications as well through this tube. So you can give both medications and food through this tube. Of course, they have to be in a liquid form. So this is a tube that is placed through the abdominal wall. It is held in place often by a balloon, which is inflated with saline during the surgical procedure, and that keeps a person from pulling that tube out of the abdomen. Or it might be held in place by a button, and this is actually an endoscopic picture of a button that is holding a gastric tube in place. You're going to learn quite a lot more about enteric tube feeding, including how to work a pump and how to connect that and how to care for a G tube or a J tube. You'll learn all about that in your residential health clinical skills labs next year. So I just want to introduce you to it briefly. There are a couple different kinds of G tubes and J tubes that can be surgically implanted. One of them is called a PEG tube, which stands for Percutaneous Endoscopic Gastronomy Tube. You can call it a PEG tube. And this is what it looks like outside the body. This is the balloon that's inflated that will be inside the stomach to hold it in place. And this is the tube, and this will be on the outside of the abdominal wall. And this is one of these is to inflate the balloon, and the other, of course, is in order to put in nutrients and medications. So when it's in place, this is what it may look like. And so a person can either tape up this tube, or sometimes they have a little belt that they wear that keeps the tube from catching on things. This is called a gastronomy button, and a very popular brand or common brand is called a MIC-KEY, so MIC-KEY, that's a brand name. And so sometimes you'll hear people refer to my Mickey, and they're not talking about, a small flask of booze in their pocket. They're talking about their gastronomy button. And again, this is the part that goes through the abdominal wall. This is a balloon that keeps it in place. But on the outside, rather than having a long tube, there's just a little button that kind of looks like an inflatable beach ball type of button. So here's this, as you can see, this bottom picture here. So this little valve then just pops off, and then you can put in an adapter that can then connect to a pump to put in food or medications then through that. So it sits much flatter on the stomach, and so it doesn't catch on things, and it's a lot less likely to be pulled out. We've talked briefly about this before, but here's the esophagus, and at the end of the esophagus there's a valve or a sphincter, and it's called the gastroesophageal sphincter. Or sometimes just called the esophageal sphincter. And it's the valve running between the esophagus and the stomach. And it acts like a one-way valve, so that it's closed most of the time, but when we swallow, food and fluid come down the esophagus, and they can pass through into the stomach, but they can't go back up into the esophagus. This is an endoscopic view of our esophageal sphincter. This top picture here is with the sphincter closed, and this is when it's open. So if you crawled through that hole right there, you'd end up in the stomach. Now, of course, the reason that this sphincter is so important is because the stomach has a very acidic environment of pH of about 1 to 2, which is, more acidic than battery acid. And the stomach itself has a special mucus lining, and so that protects the stomach lining from this gastric juice, but the esophagus doesn't have that. And so we have to protect the esophagus from this very acidic juice coming back up into the esophagus. When it does, and it occasionally does, if we eat something that increases the volume of our stomach, or we eat too much, or eat certain foods, then we do get a little wash up of that acid, and we call that heartburn. However, and it creates a burning sensation, and that's pretty normal for us to, for people to experience that once in a while. That's very different from this, which is called GERD, or gastroesophageal reflux disease. And this is where that sphincter is actually very weak. And so the acid from the stomach washes up into bathes the bottom of the esophagus on an ongoing basis. And of course, when that happens, it actually causes tissue damage. So here's a very mild case here where we actually see ulcers at the bottom of the esophagus. And of course, here we've got scar tissue starting to develop at the bottom of the esophagus. And it can be very painful, can cause problems swallowing and eating, and can permanently damage the esophageal sphincter. There is an increased risk in people with developmental disabilities, and also, interestingly enough, and I don't know why, but also people diagnosed with asthma. This damaged tissue can hemorrhage or bleed, and it can also cause a narrowing in the esophagus, which makes swallowing difficulty, and it increases the risk of esophageal cancer as well. So the main kind of treatments for GERD are to try to reduce the reflux of acid back up. So things like elevating the head of the bed so that gravity helps keep the acid in the stomach, or not lying down right after a meal, or losing weight, or not overeating. So those are all things that will reduce the amount that refluxes. Also to avoid things that cause secretion of stomach acid. So for example, certain medications, smoking, some foods like fried and fatty foods, peppermint, chocolate, alcohol, coffee, citrus, fruit and juices, and tomato products all stimulate the secretion of stomach acid, so reduce those types of foods. We will talk about drugs that can be used to treat GERD. We'll talk about that in pharmacology. And there is a surgical procedure called fundoplication, where they actually take the stomach and they wrap it around the bottom part of the esophagus to put pressure on the esophagus, which allows less acid to be moved back up from the stomach into the esophagus itself. And there's a little picture of what that procedure looks like. Okay, we're down into the stomach. Our stomach is a temporary storage tank. It prepares food for further digestion in the small intestine. So there is some both mechanical and chemical digestion that happens in the stomach itself. The stomach holds about 5 liters of food, and food will stay in the stomach for about 2 to 3 hours before moving on into the small intestine. Here's an endoscopic look in to the stomach. This is the upper stomach, which is called the fundus. This is the lower stomach, which is called the antrum. And we can just see here the valve that's at the end of the stomach and heads into the duodenum, or the first part of the small intestine. That's called the pyloric sphincter. And this is kind of a closer up view of the pyloric sphincter. So that's the entrance. If you crawled through there, you'd end up in the duodenum. So as I said, inside the stomach, digestion does take place. Mechanical digestion takes place. And this is just simply mass contraction of 3 different layers of smooth muscle. And as a result, the stomach churns and mixes and pummels food into smaller fragments. I'm going to try right now to show you a video of digestion, mechanical digestion in the stomach. Okay, so here you can see this is peristalsis inside the stomach. And I want you to watch this very muscular walls of the stomach starting to contract. You can just peek in there. You can see down there's the pyloric sphincter right there. And here comes the stomach. Whoa! I think this is a very cool video. So there you can see the mass churning of the stomach. So food that's in there gets crunched and mushed. And oh, here comes another wave of peristalsis. That's very cool. You can see the mucus lining the stomach. This is this heavy, thick mucus that protects it from that acid environment. Okay. I'm back. So these 3 layers of smooth muscle allow us to do that. There's also chemical digestion in the stomach. So if we look at the lining of the stomach, it's covered with these little pits. We call these gastric pits or gastric glands. And these pits are lined with different types of cells that produce different substances. So for example, we have goblet cells that produce the mucus that protects the stomach. We have parietal cells that make the acid. It's hydrochloric acid, and we'll discuss what role that plays in a second. And we have chief cells, and that makes an enzyme. And it actually makes an enzyme called pepsinogen, and pepsinogen gets converted into pepsin by hydrochloric acid. So these 2 substances work together in order to chemically digest food. So this is a beautiful picture inside the stomach of gastric juice, and so inside this juice there will be pepsinogen, which will get converted into an enzyme called pepsin, and the job, the substance that does that is hydrochloric acid. So there will be hydrochloric acid in there. There's also thick mucus, and there will be hormones inside that gastric juice as well. A common problem with the stomach and the digestive tract is ulcers. And ulcers are caused when the lining of the digestive tract, whether in the esophagus or the stomach or in the intestine, becomes damaged. And if the lining is damaged, then the underlying tissue is exposed. Particularly in the stomach, where there's a lot of acid, then once the protective lining has been breached, then the underlying tissue is quite sensitive to that acid, and it can literally digest itself. There's a lot of studies about what affects ulcers, but certainly there are 2 main causes of ulcers. One is a bacteria, and that's what you see, this guy right here. He's called Helicobacter pylori bacteria, and it's a very special acid-resistant bacteria. And it will destroy the lining or break down the lining of the stomach and therefore allow an ulcer to form. The other thing the other common cause of ulcers are certain drugs that break down the lining of the stomach, like ibuprofen and aspirin, and that's why they may cause gastric ulcers. So this is normal lining of the stomach, and this is after high doses of ibuprofen for quite a while, and it's broken down the lining of the stomach. So as I said, this can occur anywhere in the digestive tract. The symptoms of a peptic ulcer are stomach pain that usually occur when acid has maximally been produced, so when the acidity is at its maximum, so that's about 1 to 3 hours after a meal. As soon as somebody eats, the food in the stomach actually raises the pH, and so there's less acid and less pain right away, but it'll get worse as that food is digested. A loss of appetite, burping, nausea, vomiting, and if the ulcer itself is bleeding, then of course that blood is going to appear later on in the digestive tract in stool. So this is an ulcer right here inside the stomach. This is what we call a perforated ulcer, and this is life-threatening. This is where there's actually a hole right through the wall of the stomach that's caused by the acid and enzymes eating through that tissue. The health risks are things like scar tissue that can form and that can impair digestion, or something as severe as this, which is where the wall of the stomach just becomes perforated. Okay, we're into the small intestine. The small intestine has a couple really important functions. So first of all, this is where the majority of chemical digestion occurs. So this is where the most quantity of enzymes are, and this is where the food gets digested chemically into small molecules. The other thing is that all of the food molecules that are going to be absorbed will be absorbed in the small intestine. So this is where all that absorption occurs. The small intestine has three parts. The upper part is called the duodenum, and the lower two parts are called the jejunum and then the ileum. And here's some endoscopic pictures. These top two are of the duodenum. So this is looking up toward the stomach. So this would be the pyloric sphincter. So if you went through that little hole, you'd end up in the stomach. And this is if you turned around and then looked down. So this is down further towards the end of the digestive tract. And this is what the lining of the jejunum looks like. Okay, some little dating fun facts. How long is your small intestine? Is it 3 feet, 8 feet, 17 feet, 23 feet, or 52 feet? And the answer is 23 feet. So it's about 1.5 to 2 inches in diameter, and it's all curled up, if you think about it, just in your lower abdomen, which is still pretty incredible. So 23 feet of small intestine. If we look inside the lining of the small intestine, the cells that line the small intestine produce enzymes that break down all 3 macronutrients. So they break down proteins, carbohydrates, and fats. So these are produced in the small intestine and released directly into the small intestine. The other thing I want you to note is how the lining of the small intestine is all folded. These little finger-like projections are called villi, V-I-L-L-I. And this folding upon folds upon folds upon folds in the small intestine is absolutely crucial for food to be absorbed. The folds increase the surface area so that more food can be absorbed faster. So the food molecules enter the cells that line the small intestine, and then they move into the bloodstream. So the more surface area there is, the faster this whole process can happen. So the lining of the intestine is folded, and then if we even look closer, there's these villi that are in the lining, and if we look on top of the villi, there are even microvilli, so it increases the folding even more, the surface area even more. Okay, we have a few accessory organs that are important for digestion also. So the pancreas, our pancreas has a number of different functions. So it's going to come back, and we're going to learn some other functions when we do the endocrine system. But one of the main functions of the pancreas is to secrete enzymes into the small intestine, specifically into the duodenum, so that we can digest proteins and fats and carbohydrates. So this is the second source of enzymes. So the first source was the cells that line the small intestine itself. And then the second source is our pancreas. That's this organ right here. Our stomach would be right about here. So it just sits right under our stomach. And if we look at a close-up, we can see all these little cells. And these are the cells that produce the digestive enzymes, and they dump those enzymes into this duct, and they flow into the duodenum. So as food comes into there, then these enzymes start breaking that food down. The other thing is that we know that the stomach is protected by that really big, thick mucus layer, but the duodenum is not. And so we have to make that substance that's coming from the stomach less acidic. And the way that our body does this is the pancreas produces sodium bicarbonate, essentially baking soda, and it dumps that sodium bicarbonate into the duodenum as well. So when food enters from the stomach, it gets neutralized, that acid gets neutralized by the sodium bicarbonate, and the enzymes get dumped in to start digesting that food. Our liver and gallbladder also play a role in digestion. The liver produces a substance called bile, and then it flows down and collects into the gallbladder, and the gallbladder stores the bile, and it also concentrates it. So if you think about concentrated orange juice where the water's been taken out of, that's what the gallbladder is doing with the bile. It's making a concentrated substance. And then during digestion, the gallbladder contracts and it sends that bile down into the duodenum. And what the bile does is that it actually physically breaks down large clumps of fat into smaller ones. This is a form of mechanical digestion. There's no enzymes that happen here. It's just physically breaking big fat clumps into small ones. Just like if you had a pan that was full of bacon grease and you dumped in detergent, and it would split it up into smaller little bits. And then that allows the enzymes to come in and work better. So that's why that's really helpful, but it's really just a form of mechanical digestion. And this is an endoscopic picture, and this is bile being emptied into the duodenum. The liver does a whole lot of other things just besides producing bile, and I would like you to look that up on page 430 of your text. And this is the end of part 2. We'll come back with part 3, and I will talk to you then.